latest work. Mr. Tong, please. Good evening. As the member of the National Health Commission panel of experts, and we will brief you on the situation of the treatment of critical and severe cases in the designated hospitals for treating NCP. Upon arrival, we discuss with our colleagues the treatment plan and consult with experts and doctors in the CCM, as well as the pulmonary and respiratory discipline. And our work has been smooth and in order, and the fatality rate for severe and critical condition are decreasing, and we have seen an uprise of discharge rate. And in the Renmin Hospital and Medical Union Hospital, these two were designated as the hospital specialized to treat critical and severe cases. All of the identified severe cases were transferred to these three hospitals. And we also are in charge of the training of the medical teams coming from all over the country. We also did consultations of the treatment of severe and critical cases. Now, Mr. Zhang, please. We are the first hospital affiliated to Guangzhou University, and we arrived at February the 1st, and we began our work on the February the 2nd and 3rd, and did the renovation to the Union Hospital's infections wards. On the 7th, the second group of medical staff of 50 members, and together with their supporting staff that adds up to 57 people, take over the ICU of the Union Hospital's Western Chamber. Altogether, there are 70 beds. So altogether with our local colleagues, we now are in charge of 20 beds and 21 doctors and more than 60 nurses. We are in charge of the severe cases that needs intubation. From February the 3rd, we have treated and intubated 27 severe cases, severe patients. Mr. Zhang. In Jingtang Hospital, we have level 4, level 5, level 6, and level 7, and there are these ICU wards are jointly administrated and taken care of by 3 key hospitals in charge of clinical treatment. We are also joined by the national team of experts. Besides these 3 ICU for severe cases, the Shanghai medical team also came to our assistance in North Level 3. There's another critical case ICU there. So altogether, we have 4 ICU ward zones to ease the pressure of treating severe cases. In each ICU, we have 50 nurses, 12 doctors, and together with ventilators, monitors, and ECMO and CRT equipment, and heart diagrams, and other machines to provide all kinds of life support for the critical cases. Thank you, Mr. Zhang. Now the floor is open to questions. Please make sure to identify yourself first. With the Renmin Daily, According to the 5th edition, there has been a change in terms of clinical diagnosis. So what are the considerations of that? Does that change the hospitalization rate, and will that increase the number of confirmed cases by a large margin? Actually, when it comes to clinical diagnosed cases, normally when we are diagnosing pulmonary diseases or pneumonia, it is very commonly used. We will make diagnosis according to their history, their CT scan, and other radiology methods. We can make a clinical diagnosis. Actually, our work has improved compared to the previous ones. As a clinical doctor, it is in accordance with the clinical practice and our thoughts to add clinical diagnosis into the standard of confirming cases. After this revision, a lot of suspected cases based on the clinical standard can be included into the clinical diagnosed case and then become a confirmed case. This can make it easier for us to do administration. If it's a light syndrome, we can do like isolation, and it's also would expedite the treatment and transfer of severe cases. And so this is to provide better services and treatment to all the patients. But will that kick up the number of severe cases? Well, if we don't admit these number of suspected cases, there's going to be a large number of severe cases suspected cases that cannot be hospitalized. So we think it's better to confirm them first and then treat them in a designated location with CMG and CCTV. In terms of clinical treatment, the fatality rate of severe cases has changed. Can you tell us more about the trend of the change, and especially your methods to improve recovery rate and reduce fatality rate? Mr. Zhang, please. I want to start from a situation of my hospital. We started as a designated hospital to treat NCP, and all of them are, most of the severe cases were included in our hospital, and we also accept general cases and light syndrome cases, but right now it's a designated hospital to treat only severe and critical cases. So for severe and critical cases, the number of the patients keeps on increasing, and that would also result in an increase in the absolute number of death cases. Most of these death cases happen among the elder population as well as those with original diseases. Currently, we have a lot of policy support in terms of treatment. We have a national team of experts in our assistance. We also have a lot of national level experts in terms of critical care medicine. And we also have many experts coming from all over the country, from Fujian, Shanghai, that came in our assistance. So according to the 5th edition of the treatment plan issued by NHC, we are working now under more professional and standardized instructions and more mature instructions. And we now also have added to the use of plasma in terms of treating the patients in process of recovery, because the recovering patient will have a lot of antibodies in his and they can donate plasma to us and help us with the research, and maybe that will help the treatment of other cases, other patients. As Mr. Zhang said, we carry out a comprehensive treatment plan for the confirmed severe and critical cases. So we have a lot of special teams, doctors, nurses that joined us in this effort, which will substantially improve our capacity of treating and helping the patients to recover. And we are doing some research in terms of the usage of the plasma of recovered patients. To improve recovery rate and reduction of fatality rate, mainly concerned the following factors. First is location. Right now, most of the severe cases were handed over to major designated hospitals. And second factor is equipment. We have a lot of equipment, for example, ECMO and CRT and other ventilators. And the third factor is the chamber, or the wards, ICU, for example. And another important factor is human resources. We have special, very professional ICU teams coming from all over the country. So with all of the support, I believe that we will have better results in terms of treatment of severe cases. With the Economic Daily, can you tell us the treatment plan for the critical and severe cases? First of all, through our research of the teams of experts and our clinical practices, we have found that the novel coronavirus pneumonia is will undergo very severe restoration, and the lack of oxygen happens more quickly. But compared to SARS, they are experiencing more severe attack to the cardiac system. And the protein in their heart is increasing by a large margin under the attack. So that this will constitute higher pressure. So we have to monitor closely some of the indicators, for example, the change of blood pressure, blood oxygen, and their heartbeat. So we have to monitor them closely. And third point is that we have to carry out this life support, such as ventilators and ECMO. Strategically, we have done a lot of adjustment. Through these adjustments, we're hoping to carry out better treatment for severe and critical cases and reduce fatality rate.
我是农民日报记者提问。有数据显示，60岁以上有重度肺炎等疾病的男性感染者是高危。
There evidence shows that male of over 60 years old with original diseases is a very vulnerable group. And can you confirm that point? I think it's too early to make judgment based on one or two articles. There are a lot of different factors contributed. The time of the disease, the time that the patient seeks doctors, and the kind of medical services that he has received. If a patient's meet all of the above factors can have a fatality rate as high as 9% is not surprising. So academician Zhou Nanshan's team actually have made a conclusion and in which he studied more than 30 patients that meets all of the standard. And the fatality rate of this group of patients is even higher than 9%. So I think it's too early to tell because they have too strong a characteristics and to be used as a general guiding principle. With Hubei daily, there are a lot of severe cases that are living with high pressure and diabetes, and they are also at a very old age. So are there any special measures to treat these group of people? So still early detection, early treatment is the best policy for treating all diseases. And second is that we have to keep the original disease under control, blood pressure or diabetes, for example. Third, we have to carry out the monitor of the patients. Once there is an ominous changing indicators, we have to make early arrangement and treat the patient as a severe cases even before the situation turns worse. And so high blood pressure, and diabetes are not so horrible. We have a patient of 90-year-old that have blood pressure and diabetes at the same time, but he successfully recovered and was discharged from the hospital. So for the elderly with original diseases, they are a high-risk groups, and they constitute high-risk factors. I'll admit that, but for these group of patients, we still suggest early detection and early treatment. Because they have so many original diseases, we have to provide them with life support equipment, provide them with enough oxygen so that this damage to the body will not be irreversible. And for the elderly patient, we also have to support with sufficient nutrition. When they are under fever, they outside the hospital, they might have trouble eating or drinking water, so they might be malnutrition. And add all of those factors together will lead to deterioration of the disease and cause failure in terms of treatment. And patients with high pressure and high blood pressure and other chronic diseases, and there might be new complications emerging in the treatment, which is also something that we need to pay attention to. These patients with renal diseases, high blood pressure, and diabetes, and NCP may cause oxygen deprivation, so that will in turn deteriorate the damage caused by the original diseases, which in fact in the end might eventually lead to multiple organ failures. So for these group of patients, as the two experts said, early intervention is important. So it's important to treat the original diseases at the same time of treating the NCP.
你好，新闻广播湖北之声提问。
Is the infection higher for the severe cases than light syndrome cases? So how to protect the medical workers and how to make sure, how to guarantee the safety in the ward zone?
那么一个传染病它的传染性的大小，其实是对它这种上呼吸道这个病毒这个载量或者说数量。
So for the transmission of the disease, the transmissibility of the disease is mainly determined on the number of virus in a certain area. So according to available statistics, about 60% of the severe cases were infected both in the upper and lower respiratory tract. Some of the virus load is really high, and we also have detected virus in the feces and the blood of these severe cases. So they have a very high virus load, and the virus widely exists in the respiratory tracts, in the blood, and in feces, so that might be other channel of transmission. But for light syndrome, they have relatively lower viral load, but it's not absolute. For some elderly citizens, even if light syndrome, they will carry very high virus load. But right now, I think it's fair to say that the transmissibility of severe cases is higher than that of light syndrome because they have a higher virus load. But the light syndrome patient still has high transmissibility. So according to our statistics, in the ICU, they will have also a higher would have a higher pressure in terms of prevention of hospital-acquired infection. And that's why we conduct accumulated treatment in these 3 designated hospitals. In these hospitals, we have clear division of red zone, of the infected zone, the contagious zone, and the clean zone. And so that's the ICU of the Union Hospital. They have a buffer zone, a red zone, and clean zone. So this kind of very clear division in order to prevent hospital-acquired infection can effectively protect the safety of the medical workers and make sure that these cases are properly treated. My question is about the standard of admitting patients to the field mobile hospital, and who is to make the judgment of the transfer of the patients, and also how do the medical workers prevent the deterioration of the disease? When we're building the field mobile hospitals, we also have issued working manuals, including admission standard, discharging standard, that is transferring standard for severe cases, and division in the field mobile hospital. So in these field mobile hospitals, we also have a area for the severe cases, so we have menus to stipulate all that. In terms of transferring standard, mainly it is first standard, elderly, and after 2 days of treatment, their body temperature is still over 37.5 degrees Celsius, and the blood saturation is less than 93%. And their breathing frequency is over 30 times, and they do not have independent mobility. That is, they cannot move around on their own. So we have clear standard to do the transfer. Who is to make the judgment to transfer the patient? In each field mobile hospital, there is one hospital there in charge of administrative work, and we have multiple medical teams and workers that are in charge of different zones. The doctors are divided into resident doctors and second-tier and third-tier doctors. So the doctors will do rounds every day and to check the situation of the patients. If the patients meet all of those standards, tier 3 or tier 2 doctors will propose or suggest to transfer the doctors, to transfer the patients, and the resident doctors will make the judgment as to whether transfer this patient. So all of these all of our work are based on the menus, the checking of the temperature, the testing of the breathing frequency, and the test of blood saturation. We also have experiment to check some of the major indicators of the blood. Through all of these methods, we can make a quick evaluation of the patient's situation. I want to thank Mr. Tong, Mr. Zhang, Mr. Zhang Dingyu, and Mr. Zhang Lufu for taking the questions. That's all for today's press conference.